This conference will now be recorded.
Good morning to all. Today I am going to tell about the complications of sinusitis. First one, there are three main categories of complications. One are the orbital complications, which are the most commonest type of complications. 60 to 75% of these are of the complications of sinusitis are orbital complications. And the next one are the intracranial complications. These account for only 15 to 20%. And the bony complications, these account for 5 to 10%. These can be identified by going to radiological examination. One is the computed tomography or CT scan, best for the orbit, and next one is the MRI, which is best for intracranial extension of the complications. Coming to the orbital complications, it is the most commonly involved complication site, and it is proximal to the ethmoidal sinuses. And next are the periorbita or the orbital septum is the only soft tissue barrier. Orbital septum divides the conjunctiva from the superficial subcutaneous tissue, and the valvular superior and inferior ophthalmic veins. These are the direct communications with the cavernous sinus, which can lead to cavernous sinus thrombosis. Direct extension to the lamina propria, or the lamina propria is the bony partition which divides the ethmoid or the nasal cavity from the ethmoid sinuses, or the nasal cavity from the orbital contents. So when there is a breach of the lamina propria, it can lead to orbital complications. Another one, impaired venous dryness from the thrombophlebitis, which can lead to the superior ophthalmic vein involvement, and then it can spread to the cavernous sinus and can lead to the cavernous sinus thrombosis. Or the superior ophthalmic vein and inferior ophthalmic vein can involve the orbital contents and can lead to the orbital complications. And the progression is within the 2 days, and children are more susceptible because the bony elements are very thin and also very susceptible, and less than 7 years of age, these are isolated orbital complications like subparietal abscess can be seen, whereas in the case of more than 7 years old children, it will be mostly orbital and intracranial complications combined. Coming to the orbital complications, these are the criteria which we have to see, where the orbital complication proceeds from one step to the another. Preseptal cellulitis, next one is the orbital cellulitis, next one is the subparietal abscess, next one is the orbital abscess, and finally it can lead to the cavernous sinus thrombosis. In the picture you can see these are the orbital complications of the sinusitis pictorially. It is a periosteum, and it is the normal one. It is the normal part in the A. It is the normal picture. And second one is the orbital cellulitis. And third one is the orbital abscess, where there is a collection of purulent material within the orbital apex. And next one is subperiosteal abscess, where the periosteum, which is lining the orbital cavity, is not breached, and so there will be a collection of purulent material between the periosteum and the bony contents. Next one is the cavernous sinus thrombosis, where there is involvement of superior ophthalmic vein or inferior ophthalmic vein. It can spread to the cavernous sinus and can lead to the cavernous sinus thrombosis. First one is the preseptal cellulitis. Coming to the symptomatology, there will be eyelid edema and erythema. Extraocular movement is intact, but normal vision you will be seen, and may have eyelid abscess. CT reveals diffuse thickening of the lid and conjunctiva. Only the lid and conjunctiva are involved, but the orbital movements are normal, and there will be normal vision. Vision is not impaired, and extraocular movements are also intact. Next one is the coming to the treatment part. Medical therapy is sufficient for this. Intravenous antibiotics, and head of the bed should be elevated, and there should be warm compression in between. And we have to facilitate the sinus draining by using the nasal decongestants, mucolytics, saline irrigations, or we can go for surgical also. When we drain the sinuses by using the FES, by doing FES surgery, we can clear the sinuses from the inflammatory contents and also the purulent material, which are the underlying condition which can lead to the orbital complications. Next one is the orbital cellulitis. Coming to symptomatology, it is a post-septal infection. Septum is nothing but it divides the conjunctival part from the superficial subcutaneous soft tissue, and so anterior to the septum, it is called as preseptal cellulitis. Posterior septum, it is called as orbital cellulitis. There will be eyelid edema and there will be erythema of the conjunctiva, and also there will be proptosis and chemosis because of the edema of the conjunctiva and also the orbital contents. Limited or no extraocular movements, and there will be no visual impairment because the orbital orbit which is intraorbital contents are not involved, and there will be no discrete abscess. It is a low attenuation adjacent to the lamina papyracea on the CT. You can see here, and normal eye it will look like this, whereas in the case of periorbital cellulitis it will look like this. There will be erythema of the conjunctiva, eyelid edema, and orbites or periorbital contents are mostly involved. In this, we have to facilitate the sinus drainage. As I have said previously, whenever you clear the sinuses, the patient may get into the normal conditions. And coming to the medical therapy, it will be IV antibiotics. Head end of the bed should be elevated, and there should be warm compresses in between. When there is a visual acuity of 20/60 or more worse, we have to go for surgical drainage. And if there is no improvement or progression within the 48 hours, also we have to go for surgical drainage. You can see here preseptal cellulitis and orbital cellulitis. Preseptal, there will be proptosis will be absent in the case of preseptal cellulitis. Only the anterior subcutaneous part of the tissue is involved, whereas in the case of periorbital cellulitis, there will be proptosis because of the periorbital contents are involved, and it will lead to the pushing of the eyeball anteriorly. And the mobility is normal in the case of preseptal cellulitis. It is decreased in the case of orbital cellulitis. Orbital pain is absent in the case of preseptal cellulitis, whereas in the case of orbital cellulitis, there will be orbital pain will be present. Vision is normal, and there will be decreased vision in the case of periorbital cellulitis, and the pupillar reaction is normal. It will be normal. These all conditions will be normal in the case of preseptal cellulitis. Only chemosis will be very much rare because the conjunctiva may involve in some patients, and systemic signs and symptoms are also minimal in the case of preseptal cellulitis. Whereas in the case of orbital cellulitis, there will be decreased vision, pupillary reaction will be often pupillary defect or maybe abnormal, and the chemosis will be common because of the involvement of the conjunctiva, and corneal sensation will be decreased, and ophthalmoscopically there will be abnormal or venous congestion with or without disc edema, and severe systemic symptoms will be severe in this case of orbital cellulitis. Coming to subparietal abscess, it is a pus formation between the periaorta and the lamina papyracea. That is periorbital periosteum will be there. No, it is called as periaorta. There will be a collection of pus between the periosteum or periaorta and the lamina papyracea, which is a papillary thin bone which separates the nasal cavity from the orbital contents. Lamina papyracea displays the orbital contents downwards and laterally, and so there will be proptosis because of this, and there will be chemosis and ophthalmoplegia. There will be risk for residual visual sequelae, that is decreased vision or damage to the retinal contents or intraorbital contents, may lead to the rupture, may rupture through the septum and present in the eyelids. It is a picture showing a subperiosteal abscess. There will be proptosis, chemosis, and proptosis is nothing but pushing of the eyeball anteriorly. These are the ethmoid sinuses. Because of the involvement of the ethmoid sinuses, there will be collection of pus through the lamina papyracea. It is the periorbital or periorta or periosteum, and it is the papillary thin lamina papyracea. And the pus is collected in between. It can lead to subperiosteal abscess. Surgical drainage, we have to go for surgical drainage in these cases. Worsening will, what are the indications for surgical drainage means there will be decreased visual acuity or the decreased extraocular movements, and there is any lack of improvement after the 48 hours of medical therapy. may be treated medically in 50 to 67% of the cases. And open the ethmoids and remove the lamella papillae. That is, remove we have to keep the periosteum or the periaorta intact, and only we have to remove the lamella papillae so that the pus will be drained into the nasal cavity. Approaches are external ethmoidectomy by the incision is most preferred. Endoscopic ideal for the medical abscesses, and transcaruncular approach, transconjunctival incision, extend the medially around the lacrimal caruncle. These are all not much important. Remember about the FES, which is functional endoscopic sinus surgery, where we have to clear the uh, inflamed or infected sinuses. That is ethmoid sinus most common. We have to clear the sinuses, open the sinus, and we have to keep the patency of the sinus openings. Or coming to the orbital axis, pus formation within the orbital tissues, and there will be severe exophthalmos and chemosis, and there will be ophthalmoplegia, and there will be visual impairment. There will be risk for irreversible blindness because of the damage to the orbital contents, and it can spontaneously drain through the eyelids. You can see the picture here. It is the orbital axis. There is edema of the eyelids and chemosis, and there is exophthalmos, and because of the involvement of the orbital contents, there will be decreased vision and can lead to the permanent visual loss. You can see here, it is the abscess, collection of pus in the orbital contents. This is the breached part. We have to incise periaorta or periosteum and drain the intracorneal abscess, and similar approaches as with the subperiosteal abscess, and Lynch or endoscopic approaches. That means in the case of subperiosteal abscess, the periaorta or the periosteum is kept intact, whereas in the case of orbital abscess, we have to incise the periaorta or the periosteum, and we have to drain the abscess. That is a major difference here, and there will be irreversible visual loss in the case of orbital abscess, whereas in the case of subperiosteal abscess, the orbital vision is preserved. And coming to the last one, it is a cavernous sinus thrombosis. Symptomatology are orbital pain, proptosis and chemosis, ophthalmoplegia, and symptoms in the contralateral eye because of the involvement of bilateral connection of cavernous sinus with the bilateral superior ophthalmic veins and inferior ophthalmic veins, and it can lead to sepsis and meningismus because the cavernous sinus can drain into the IJ, that is internal jugular vein, and can lead to systemic sepsis. And radiology, there will be poor venous enhancement on the CT, and it is best visualized on the MRI. You have to remember this. There can be sepsis and meningismus, and there can be involvement of the contralateral eye because bilateral superior ophthalmic veins and the inferior ophthalmic veins are connected by cavernous sinus. And so, whenever there is a cavernous sinus thrombosis, it can spread to the contralateral eye also. There can be ophthalmoplegia. Ophthalmoplegia nothing but involvement of the third, fourth, and sixth cranial nerves, and there will be decreased eyeball movements, and there can be proptosis because of the orbital edema and chemosis, and there can be orbital pain. You can see here it is a cavernous sinus. Whenever there is a thrombosis, it can lead to the opposite cavernous sinus involvement because of the intercavernous sinus connections anterior to the pituitary gland. It is a CT showing, this is MRI showing the cavernous sinus thrombosis. Coming to the intracranial complications, these occur more commonly in the case of chronic rhinosinusitis, and mucosal scarring and polypoidal changes. These are the most common findings, and there can be hidden infection foci with poor antibiotic penetration, and male teenagers affected more than the children. In the case of children, there will be orbital complications, whereas in the case of adults or the male teenagers, there will be involvement of intracranial complications, and direct extension through the sinus wall erosion because the sinus walls are very much thin uh, uh, when compared to the other body bones. So there will be involvement of the surrounding structures in the case of chronic rhinosinusitis, and the traumatic fracture lines where repeated trauma can lead to the dislodgement of the joints between the ethmoids and the maxillary bone or the sphenoid bone, which can lead to spread of infection through these crevices and into the intracranial cavity. And there can be neurovascular phenomena through the neurovascular phenomena. This is optical and olfactory nerves, and which are directly communicate with the nasal cavity. And there can be hematogenous spread through the diploic skull veins or the ethmoid bone. And these complications are meningitis, epidural abscess, subdural abscess, intracerebral abscess, cavernous sinus, venous sinus thrombosis. These are the main complications. Meningitis, first one, which is the most common complication. Next are the epidural abscess, that is outside the dura only. There is no penetration of the dura in the case of epidural abscess, whereas in the case of subdural abscess, there is it is deep to the dura mater, and whereas in the case of intracerebral abscess, there is abscess within the cerebral hemisphere or intracerebrally, or they can be cavernous sinus or venous sinus thrombosis. Coming to the symptomatology, fever is more common, 92% of the cases. Next is the headache, 85%. Next are the nausea and the vomiting because of the involvement of the intracranial contents. And there can be altered consciousness, seizure, hemiparesis, visual disturbances, and there can be meningitis, similar to the meningitis symptoms. Coming to the meningitis, more common symptoms are headache, meningismus. Meningismus nothing but irritation of the meninges, and there can be fever, septic symptoms, and there can be cranial nerve palsies. And because the most commonly cranial nerves which are in close proximity to the sinuses are optic nerve, olfactory nerve, fifth cranial nerve, fourth cranial nerve, and also the third and sixth, which are in close proximity. 3, 4, 6, and 5, you can see they pass through the cavernous sinus. And so whenever there is a cavernous sinus involvement, there can be involvement of cranial nerves. And the sinusitis is unusual cause of meningitis, sphenoiditis, and ethmoiditis. Usually amenable with the medical treatment. Uh, we can go for direct medical treatment. We have to drain the sinuses if no improvement after the 48 hours of medical therapy. And there can be hearing loss and seizures equally, because in the case of meningitis, uh, the ear can also be involved directly through the cochlear aqueduct, and because there is a direct communication of the ear endolymph and perilymph with the intracranial fluids, and so it can lead to the calcification of the cochlea and can lead to the hearing loss, and seizures equally can be present. Next is the epidural abscess. It is the second most common intracranial complication next to the meningitis. Generally, it is a complication of frontal sinusitis. Symptomatology are fever 50% of the cases, headache, nausea, vomiting, papilledema because of the intracerebral involvement, epidural abscess, no, because papilledema because of edema, mostly edema, and the next one is the hemiparesis. Next one is the seizures. Lumbar puncture is contracting agent of epidural abscess, and next one is prophylactic seizure therapy is not necessary because of the absence of involvement of the intracranial contents. Mainly treatment is with antibiotics, and typically for 4 to 8 weeks, and then we have to go for drainage of the sinuses and the abscess. And in the case of frontal sinus involvement, we can go for frontal sinus trephination. That is, small hole is created over the medial canthal area, medial canthus of the eye, above the medial canthus of the eye, and we have to drain the drainage through the nasally by pushing the contents via the using the syringe. And next one is the frontal sinus cranialization. That is, complete frontal sinus should be in communication with the cranial cavity. That is, complete closure of the frontal sinus drainage pathway should be closed, and only the frontal sinus should be communicated with the cranial cavity. It is uncommon, and frontal and frontoparietal lobes involvement are uncommon. Generally, from the frontal sinusitis, it is more common. That is, frontoparietal lobes or frontal lobes involvement. Next one, the sphenoid, ethmoids, mortality rate is 20 to 30%. Neurological equally are more common in these cases. Next one is the subdural abscess. generally from the frontal or the ethmoid sinusitis, and it is the third most common intracranial complication. There can be rapid deterioration in these cases, and residual neurologic sequelae are more common, accompanies 10% of the epidural abscess. Symptomatology mainly headache, fever, nausea, vomiting, hemoparalysis, lethargy, and coma. Lumbar puncture is potentially fatal because of raised intracranial tension. There should be aggressive medical therapy with antibiotics, anticonvulsants, hyperventilation, mannitol to decrease the cerebral edema, and steroids also to decrease the cerebral edema. We have to drain the sinuses and also the abscess. Medical therapy possible if there is less than 1.5 centimeters of the subdural abscess. Craniotomy or stereotactic burr hole should be created, and endoscopic or external sinus drainage should be done. Coming to the intracerebral abscess, it is the uncommon. Mostly frontal and frontoparietal lobes are involved, and generally from the frontal sinusitis, sphenoid or ethmoid sinusitis. And the mortality rate is 20 to 30%. Neurological sequelae are more common in this case because of the involvement of cerebral hemispheres or intracerebral contents. There can be nausea and vomiting. Seizures are also more common. Meningismus and papilledema can also be observed in these cases. Symptomatology mostly headache. Next one is the mental status change. Next one is the focal neurological deficit. Next is the fever. Because intracranial contents are involved, it can lead to headache, mental status change, focal neurological deficit, and fever. Next one is the bony involvement, which can lead to the Pott's Puffy tumor. Pott's Puffy tumor is most commonly in the case of frontal sinusitis, and there will be acute osteomyelitis of the anterior frontal wall of frontal sinus wall, and there will be damage to the anterior frontal sinus wall, which can lead to subperiosteal pus collection, which can lead to the puffy fluctuance. It is a rare complication. Only 20 to 25% of the cases are seen in the post-antibiotic era. It is a picture showing the Pott's Puffy tumor here because of the involvement of the anterior table of the frontal sinus. You can see in the picture here. Symptomatology: headache, fever, neurological sequelae, and also periorbital or frontal swelling, and nasal congestion and rhinorrhea. Coming to the conclusion, complications are less common with the antibiotics, mostly orbital, intracranial, bony, and can result in gastric sequelae. We have to drain the abscess and also drain the sinuses. And okay, remember this sequelae, Chandler's criteria. Chandler criteria. That's it. First, preseptal cellulitis. Next one is the orbital cellulitis, that is periorbital cellulitis. Next one is the subperiosteal abscess. Up to here, the involvement of the intraorbital contents are less, whereas in the case of orbital abscess and cavernous sinus thrombosis, there will be orbital contents are involved here. These are the pictures. For all these cases, we have to go for medical management firstly, and next one is surgical drainage. In some cases, the vision cannot be preserved. In some cases, vision can be recovered. These are the intracranial complications: meningitis, epidural abscess, subdural abscess, intracerebral abscess, cavernous sinus, and venous sinus thrombosis. These parts of the tumor. Thank you.
This conference will now be recorded.